Hello and welcome everyone for today's webinar on imaging vascular anomalies using raster scanning optoacoustic mesoscopy, or Rsom. I am Dr. Andrew Brannon, Application Specialist for Ithera Medical, and I will be moderating this session. The webinar itself will last for approximately 40 minutes, and we very much encourage questions. If you maximize your go-to tool, you can see a question box where you can type in questions and we will answer them at the end. This webinar is also being recorded and we will send a link to all registrants in a few days. Our speaker today is Emily Geisler, who is a fourth-year medical student at the Herbert Wertheim College of Medicine in Miami, Florida. She spent a year between 2019 and 2020 working for Dr. Alex Kane and Dr. Rami Halleck at the University of Texas Southwestern Medical Center in Dallas, Texas, where she used Rsom for characterizing vascular anomalies as her main research project. She has recently matched into a plastic surgery residency at the University of Texas Medical Branch in Galveston, Texas, where she will begin her training this summer. Thank you for presenting your work today, Emily, and I will now pass control over to you.
Thank you very much, Andrew. Good morning, everybody. My name is Emily, and I'm excited to be giving this talk on behalf of the team at UT Southwestern and Children's Health in Dallas, Texas. So today I'm going to be presenting to you our project titled 3D Imaging of Vascular Anomalies using Raster Scanning Optoacoustic Mesoscopy. Quick disclosure here, Dr. Andrew Brannon is an author on our paper and he's an employee of Ithera Medical. Before we begin, I'd like to set up a brief outline for today's discussion. I'll be providing an introduction into capillary malformations and infantile hemangiomas, which were the target pathologies of our study. We'll discuss their clinical and pathological features, as well as the usual treatment. Next, we'll discuss why we turn to Rsom to help us improve the way that we treat them. I'll be discussing the technology and how we applied it to the study of these lesions, and what we found in doing so. Finally, we'll discuss the directions that we'd like to move in the future and how we think Rsom technology may improve clinical outcomes for the study and management of these common but difficult to treat vascular anomalies. Now, where everything began, the Analytical Imaging and Modeling, or AIMS Center, is a non-radiologic imaging lab located inside Children's Medical Center in Dallas, Texas. Dr. Alex Kane, pediatric plastic and craniofacial surgeon and the division director, created this lab as an imaging core offering non-radiologic imaging such as 2D, 3D, and 4D imaging capture used for clinical and basic science research, as well as for clinical treatment optimization. Dr. Kane leads the lab along with Dr. Rami Halleck, an imaging scientist and the backbone of the lab. Dr. James Seward and Dr. Chris Derderian, both pediatric plastic and craniofacial surgeons, also lead projects within the AIMS Center. Both Dr. Kane and Dr. Seward have a particular interest in treating pediatric vascular anomalies such as capillary malformations and hemangiomas, which led to their interest and eventual involvement with Ithera and the raster scanning optoacoustic mesoscopy research. I got involved with Dr. Kane at the AIMS Center in 2019. Like Andrew said, I'm a fourth-year medical student at the Herbert Wertheim College of Medicine in Miami, Florida, and I'll actually be graduating in a few days. I took a one-year break from my studies to pursue research with Dr. Kane at the AIMS Center. And one of my main projects was working with the Rsom laser, which is what we're going to be discussing today. And I'm recently matched into a plastic surgery residency at the University of Texas Medical Branch in Galveston, where I'm going to be starting my training this July. Now, to begin our discussion, the International Society for the Study of Vascular Anomalies has a classification system for defining vascular anomalies. This table divides vascular anomalies into two major categories: vascular tumors and vascular malformations. As seen here, capillary malformations fall into the simple type of vascular malformation. Infantile hemangiomas fall under the benign vascular tumor category. Before we begin discussing capillary malformations, I wanted to touch on a brief note on the history of the term port wine stain. Port wine is a fortified wine originating in 17th century Portugal. The Romans started making this wine in the Douro River, where port is still made today. This wine was heavily exported to England, where it earned its name from being exported from the city of Oporto, Portugal. and the term port wine stain comes from the purplish skin discoloration appearing as if port wine was splashed onto it. Capillary malformations are among the most common vascular anomalies with an incidence of 3 in 1,000 births. Incidence in males and females are equal, although some sources report a 3-to-1 female to male distribution. They're present at birth and they involve a varying degree of anatomical surface area, most often in the head and neck, along the trigeminal nerve distribution, and can involve delicate areas of the face such as the nose, the lips, and the eyelids. These lesions do not resolve on their own and they grow with the child. Early treatment is vitally important because if left untreated, these lesions tend to become darker, thicker, and irregular in surface, known as cobblestoning, which can be extremely difficult to treat as well as cause devastating functional, social, psychological, and cosmetic effects. Although the mechanism of development is not yet fully understood, what we do know is that capillary malformations develop embryologically when mutations cause normal blood vessels to grow in increased size and number within the skin around day 48 of gestation. This initially leads to a histologically normal but structurally abnormal lesion, although if left untreated, the ectatic vessels and fibrosis become more evident with time, as seen in these histologic slides. The development of the vascular system is influenced by the autonomic nervous system, which is why capillary malformations often occur in the trigeminal nerve distribution. Most capillary malformations are sporadic and are not associated with a syndrome. The GNAC gene, encoding for a protein involved in blood vessel growth, has been implicated in the majority of capillary malformations, but the pathogenic mechanism is thought to be multifactorial, especially in syndromic cases. Infantile hemangiomas are the most common benign tumors of childhood, with an incidence of 4.5% of all infants, and are more common in females and in preterm infants. Anatomically, they also occur in the head and neck. These tumors present within the first few weeks of life and have a characteristic life course consisting of 2 major stages. The first stage, proliferation, occurs within the first year of life and consists of rapid growth of the lesion, becoming more elevated, rubbery in texture, and can develop complications such as pain and ulceration. It's vital for physicians to monitor the lesion growth during this time to manage any potential complications, such as bleeding, infection, airway obstruction, or visual or auditory compromise. During the first stage, infantile hemangiomas can be classified based on their depth as deep, superficial, or mixed. On the left is a superficial infantile hemangioma, visible at the skin surface. On the middle is a deep infantile hemangioma with no surface involvement. And you can see how this tumor may cause breathing issues for this infant given the location on the neck if it was to grow significantly larger. And on the right is a mixed infantile hemangioma with both superficial and deep components. The second stage, involution, begins within 6 to 12 months after birth and can last several years, although most tumor regression occurs by the age of 4 years. During this stage, the tumor shrinks and lightens, usually occurring first in the center of the lesion, causing a central clearing. The tumor cells are replaced by fibrofatty tissue, causing a variable degree of remaining deformity. Once involution is complete, about 50% of tumors have residual bulk, discoloration, and skin redundancy, which can be unsightly as well as cause functional deficits depending on the anatomic location. Treatment at this stage is often sought to improve appearance and functioning for the child, unless complications warranted earlier treatment. The exact mechanism of formation of infantile hemangiomas is unknown. What we do understand is that aberrant proliferation and migration of hemogenic endothelial cells cause the development of infantile hemangiomas during fetal growth. These cells may either be intrinsic endothelial progenitor cells, known as EPCs, or angioblasts from placental origin. Histologically, these lesions change significantly throughout their growth phases. Early proliferative lesions are well circumscribed, encapsulated masses of capillaries with characteristic plump endothelial cells. As the proliferative phase transitions to the involution phase, capillaries begin to disappear and fibrofatty tissue becomes predominant, as you can see in these histologic slides. Before we discuss the usual treatments for capillary malformations and infantile hemangiomas, there is an underlying theme regarding their treatment that caused us to turn to the Rsom technology. Treatment plans for these lesions are usually developed based on a physician's subjective assessment. There are no objective ways to evaluate these pathologies and develop a treatment protocol that maximizes effect and minimizes complication. In addition, the results of treatment are varied, and not every patient receives a satisfactory outcome. Finally, each treatment method carries its own risks, such as burns, scars, and the risks involved with medical management. Because of this, we sought to gain knowledge about these lesions in an objective way using imaging to see whether we could classify the features of each lesion. Could this help us refine our treatment techniques? Our question was, can Rsom help us clinically in the treatment of capillary malformations and infantile hemangiomas? Before we discuss Rsom, I'd like to touch on how we treat them. Treatment of capillary malformations should ideally begin early, before the progression to hypertrophic stages. The gold standard for treatment is Pulsty laser. This treatment, however, only shows a satisfactory diminishment in pigmentation in about 70 to 80% of patients, and usually requires a series of treatments which may take years. In addition to taking a long time and requiring compliance with therapy, we expose the child to multiple rounds of sedation or general anesthesia to perform these procedures, which carries its own risk. Complete resolution of the lesion is unusual. Generally, the results from laser treatment depend on the skin type and location. Among facial capillary malformations, the midface and the V2 distribution is the most difficult to treat. Treatment with Pulsty laser carries risks of burns, hyperpigmentation, hypopigmentation, or scarring. In addition, there have been reports of the lesions redarkening in the years after. Some lesions stop responding to treatment after about 6 to 10 sessions, and some lesions are minimally responsive, requiring alternative types of therapy. So clearly, although this is the gold standard for treatment at this point, there's still plenty we need to learn about how to best manage these anomalies. So what exactly is the Pulsty laser, and how does it treat these lesions? The Pulsty laser uses a high-energy source of visible light to excite a certain dye to a state of being able to emit simulated radiation. Light can either be reflected, transmitted, or absorbed by a target, but absorption is what's responsible for clinical effect because it's converted to thermal energy in the targeted tissue. The wavelength of the laser light is preferentially absorbed by specific chromophores, as seen in the absorption coefficient chart, which allows the laser to selectively target specific structures. We have 4 endogenous chromophores in the human body: hemoglobin, oxyhemoglobin, melanin, and water. In the Pulsty laser, the chromophore is oxyhemoglobin, allowing the laser to cause selective photothermolysis in blood vessels and limiting damage to other chromophores such as melanin. The vessels must be heated to at least 70 degrees Celsius for successful closure, destruction, and eventual clearing of the vessel by a local inflammatory reaction, as seen in the diagram on the right displaying the mechanism and timeline of PDL on the ectatic vessels. Within minutes upon treatment with PDL, photocoagulation and thrombosis occur in the ectatic dermal vessels, initiating the inflammatory process which results in vascular remodeling over the next several weeks. The laser reaches a depth to about 1.5 millimeters and selectively targets vessels 55 to 150 micrometers, meaning that small, superficial vessels are the best targets for PDL. Now, when the gold standard treatment doesn't work or stops working after a series of treatments, we have several options for our patients. It's often the case that when a lesion stops responding to treatment, a deeper penetrating therapy is needed to resolve the remaining pigmentation. Longer wavelength lasers penetrate to greater depths, allowing deeper vessels to be thermalized. Deeper penetration carries more risk of deep dermal burns, which can cause scarring, so great care must be used. Due to the histologic heterogeneity of capillary malformations, especially as time goes on, a combination therapy may be used to target vessels of different sizes and at different depths, and even with a different chromophore to more selectively lyse venous or arterial capillary ends. For example, the 1064 nanometer laser can penetrate 5 millimeters into the skin, reaching the subcutaneous fat layer. This therapy can be used alone or combined with the 595 PDL. The KTP laser uses the KTP crystal, which can be engaged by the ND-YAG laser, producing a 532 nanometer wavelength and selectively targeting oxyhemoglobin. There are a few alternative therapies that can be effective for refractory lesions. Intense pulse light is an alternative to laser therapy that uses variable pulse durations and wavelengths, providing a broader range of targets. Photodynamic therapy started as an anti-tumor therapy and involves topical or circulatory administration of a chromophore that becomes highly concentrated in the malformed vessels. The lesion is then treated with a laser to selectively destroy the ectatic vessels. Anti-angiogenic therapy combines PDL with topical anti-angiogenic agents such as rapamycin. These alternative therapies may be effective for refractory lesions. However, they're not widely used and more research is needed on their safety. Our experience with laser treatment reflects what is seen in the literature. As we stated before, development of a laser treatment protocol is based on subjective evaluation by the physician and not set on any objective measurements or algorithms. The same laser treatment method can yield resolution of discoloration in some, as seen in patient A, while in others cause a burn, as seen in patient B. These are actual cases from our clinic and participants in our research study. The treatment of infantile hemangiomas depends on the location and the size of the lesion, as well as how much involution occurs on its own within the first few years of life. Ideally, the lesion will involute without complication, leaving minimal signs of its presence and no functional or cosmetic impairment to the child. Infantile hemangiomas that should be treated before waiting for involution to conclude are those that have become complicated for a variety of reasons, which we touched on before. Ulceration is the most common complication, occurring in up to 20% of infantile hemangiomas, and is associated with the proliferative phase of the lesion. In addition, large lesions or those in anatomic locations at risk of causing disfigurement, eating or breathing difficulties, or sensory impairment may warrant early intervention. Early treatment may also be sought to arrest growth of the lesion, minimizing potential disfigurement. For such lesions, there are a host of treatment options. Medical management with systemic propranolol, a beta blocker, has been shown to be effective in arresting growth of infantile hemangiomas. Beta-2 receptors are prevalent in proliferating capillary endothelium, and blockade of this receptor has shown a downregulation in growth factors and diminished differentiation of infantile hemangioma stem cells into vascular structures and promotion of adipogenesis. Corticosteroids are another medical option and can be used both systemically, intralesionally, or topically. Steroids slow the growth and decrease the size of these tumors. When medical therapy fails to result in a satisfactory outcome, treatments with Pulsty laser or surgical removal or debulking may be sought. Often, children with complicated infantile hemangiomas are treated with a combination of therapies to maximize benefits and minimize potential treatment complications. Although we have several treatment options for our patients with capillary malformations and infantile hemangiomas, as you can see, no treatment method is universally effective, and the results are varied and unpredictable. In addition, there is no treatment algorithm based on objective measures that may help a physician decide which way to go. The ability to characterize the structure of these vascular malformations may offer some insight. Our question was, can Rsom help us do this by giving us a method of studying the vascular microstructure? Can our findings with Rsom help us understand why the response to treatment, especially with therapeutic laser, is so varied among patients? So now, what is Rsom? Raster scanning optoacoustic mesoscopy, or Rsom, is an emerging, non-invasive imaging technology that provides morphological and functional information from the tissues. Rsom combines the resolution of optic imaging with the deeper tissue penetration of ultrasound detection, producing higher resolution images of tissues at greater depths than optical imaging alone. As seen here, it uses a 532 nanometer pulse light laser to excite hemoglobin, causing thermoelastic expansion and generation of ultrasound waves. These waves are then mathematically converted to a high-resolution 3D image of the tissue. On the left is a picture of the actual Rsom Explorer C50 laser that we used. In the middle is a graphic representation of the raster pattern that the laser follows to create a 3D picture of the tissue. And on the right is a simple illustration showing what structures are visualized and how they appear in the scan. With a penetration depth of 3 millimeters, Rsom provides microstructural information at the mesoscopic scale, or down to tens of micrometers. As seen in this scan, Rsom can clearly display a snapshot of the superficial features of the tissue, such as the superficial and deep horizontal plexus seen in red. The high-frequency signal in green displays smaller vessels and structures. The low-frequency signal in red shows the larger structures. These signals can be viewed simultaneously or separated out during analysis to study structures of smaller and larger sizes, respectively. The ability to see the microvasculature was of particular importance to us in scanning patients with vascular anomalies. Because this is the first known clinical application of Rsom to study vascular anomalies, we needed to develop a method of analyzing the scans. And for that, we took a first step by studying telangiectasias. These common dilated superficial vessels provide a simple and easily accessible subject of study. For the first part of our study, Rsom scans were obtained on 4 healthy female subjects with telangiectasias on their legs. For each vessel, we assessed the length and calculated the volume. To obtain these values, the vessel was segmented from the surrounding tissue using image thresholding. We separated the low-frequency signal in red to isolate the larger telangiectasia vessel from the surrounding smaller vessels in green before segmenting it. We compared the volume that we obtained from manual segmentation with several best-matching auto-segmentation options by using the Dice similarity coefficient, intraclass correlation coefficient, and ANOVA testing. The length was directly measured on the skin and in the scan. Here's an Rsom scan of a telangiectasia, where the wishbone-shaped vessel appears in red, seen just beneath the epidermis in green. The XY dimension shows a top-down view, and the ZY dimension shows a cross-section. Segmentation of the vessel from the surrounding tissue using image thresholding can be seen in the 3D image, which corresponds to the clinical photo of the vessel. Segmentation is important to separate the target vessel from the surrounding tissue noise in order to calculate the volume and view the unique vessel structure. Here's the telangiectasia scan before and after image segmentation using manual and automatic thresholding. The pixels in red are included in the volume calculation, while all other pixels are ignored. Finding an automatic segmentation method is important to avoid the user subjectivity of manual thresholding when calculating the volume. The spatial overlap of how vessels were segmented was compared across all thresholds using Dice, which achieved over a 90% similarity. The green pixels are what was included by the automatic segmentation method that differed from the manual segmentation. The volume was compared across all 5 threshold groups, which showed a greater than 92% similarity. ANOVA testing on mean volumes within the threshold groups resulted in a p-value of greater than 0.05, indicating that there was no significant difference between the means. Vessel length was obtained using an XY projection of the vessel. A 3 by 5 millimeter frame, seen here in yellow, was applied around the vessel to isolate the specific structure scanned, which reflects the field of view of the Rsom. The ruler in the image shows the millimeter scale. The vessel lengths and structure were successfully correlated between the scan and on the scan. Now that we validated the information we were obtaining from the Rsom laser and had a method for calculating blood vessel volume, we applied these techniques to studying vascular anomalies. Using the methodology that we developed, we studied capillary malformations and infantile hemangiomas in patients who were undergoing a series of therapeutic laser treatments. We obtained a total of 3 scans per patient in the operating room: pre-treatment affected, post-treatment affected, and an unaffected skin region. Our patient population consisted of 9 total patients, 6 with capillary malformations and 3 with infantile hemangiomas. Most patients were males, and the mean age was 6.5 years at time of Rsom scan. Most patients were receiving their first laser treatment to the area that we were scanning, and most of the lesions were on the head and neck. The laser used in all cases was an ND-YAG at 532 nanometer wavelength. Seen on the right is one of our patients with an infantile hemangioma on the cheek. This is a good case to display the redundant mass and discoloration seen once the involution process is complete. In this child, laser treatment was used for the telangiectasia vessels as well as surgical debulking to reduce the tumor mass. So how did we do the actual scanning? Once the patient consented for participation, on the day of surgery, we brought the Rsom laser into the operating room. Upon induction of general anesthesia, we would examine the area being treated to see which portion would lay the flattest and allow enough space to accommodate the laser scanning head, which you can see in the image. Once we found a good spot to scan within the affected skin, we measured and photographed the area. We also established landmarks both anatomically as well as with the orientation and angle of the scan head so that we could repeat the scan after treatment. Once a satisfactory scan was completed, the patient underwent their laser treatment by the surgeon. As soon as their treatment was completed, we brought the Rsom laser back to the patient and repeated our scan in the same spot that we scanned before treatment. We would then do an additional scan on an unaffected skin region in a similar anatomic area for comparison. Here are examples of pretreatment scans of the infantile hemangioma and capillary malformation that we saw before in previous slides. In the middle is the XY view, which is top down, as if you're looking straight down onto the skin. And on the right is the ZY view, which shows a cross-section of the tissue. Here's that same infantile hemangioma shown before and after receiving laser treatment. There are some changes here that we can see. First, the most superficial layers of the skin in green appear more diffuse, which could be due to a slight change in angle of the scan head. Although this has no effect on the calculations, it's simply a display phenomenon. The deeper, thicker vessels in red appear less dense, which may be due to the effect of the treatment laser. As we know from previous discussion, within minutes of treatment laser being applied to the skin, a process of thrombosis and thermolysis occurs in the affected vessels. This process could potentially be causing the visual changes that we see here in these images. For the pathology scans, we calculated the blood vessel volume for each pathology type. We separated the high and low frequency signals in green and red respectively to do this calculation. We compared the pre-treatment, post-treatment, and unaffected volumes for each pathology type. The mean volumes were compared using a student's t-test. What we found for capillary malformations was that there was an overall increase in volume for both the high and low frequency signals between pre and post-treatment. For the low frequency signal, this difference was statistically significant. In the high frequency signal, there was also a significant difference between the post-treatment and unaffected skin blood vessel volume. For infantile hemangiomas, we found an overall decrease in volume from pre to post-treatment, although this difference was not significant in either frequency. There was a significant difference in the pre-treatment and unaffected skin volume in the high frequency signal. Based on these results, we have a few discussion points to make. This is the first clinical application of Rsom to the study of cutaneous vascular anomalies, such as capillary malformations and infantile hemangiomas. Additionally, Rsom provides valid information that can be expanded upon to provide clinically useful information. Because this is such an innovative technology, more research is needed to develop methods that can be applied in a clinical setting. We noted volume changes in our studies from pre to post-treatment, with an overall increase in volume in capillary malformations and a decrease in volume in infantile hemangiomas. Because these are different pathologies, it's not surprising that they behave differently to the same laser treatment. We're investigating the possible causes of these volume changes that occur immediately upon the conclusion of laser treatment. Given the effect of laser on the vasculature, could these changes be due to thrombosis, thermolysis, inflammation, or rerouting of blood? Some questions still remain, providing future direction for our study. Our study had limitations. First, it's difficult to scan the lesion in the exact same location every time, especially when having to do scans at different points in time or by different users. We took several precautions for this, such as documenting our scan location, scan head orientation, measuring the exact location, and having the scans be done by the same user. In addition, our cohort of patients is small. Although these are common pathologies, not every lesion or patient is amenable to being scanned. We do recruit every potential patient who's being treated in our clinic, and this is a longitudinal study which has only just begun. We wanted to touch on the usability of the Rsom laser in a clinic and operating room setting. Because of the limits of angling with the scan head, we were required to adjust the position of the patient in the operating room to allow for a flat surface. This can be difficult when a patient is intubated, as there's a limit to rotation of their head that is safe and that can be maintained for the duration of the scan. In addition, the patient must be completely still for the 2-minute duration of the scan. This is easier when the patient is under general anesthesia, but it can be difficult if performing the scan on an awake individual, such as when we did the scans on the legs of adults with telangiectasias. Luckily, there are ways to adjust for motion in post-processing, but stillness is still required for quality scans. Finally, we do therapeutic laser treatment for our patients at multiple locations in Dallas. Although the Rsom laser is mobile, as you can see, it is on wheels, it's not easily transportable to multiple freestanding sites, so our study was limited to the patients being treated at the main children's hospital. However, because the laser is mobile, this allowed us to use it in both the clinic and operating room setting within our hospital, which is what made this study possible. Future directions for our study include recruiting a larger sample size, as well as following these patients, both new and existing, in a longitudinal way, so that we can observe any changes in the lesions once the process of inflammation has resolved. We would also like to observe how the lesion may change after a series of several treatments. We would like to find ways to further characterize the lesion features that may offer insight into why they behave the way they do to the treatment that they get. This may allow us to predict their behavior, which could contribute to developing a treatment protocol that's objective and individualized to that patient and to their unique pathology. Our ultimate goal is to develop objective measures that allow us to refine our treatment methods for capillary malformations and infantile hemangiomas, minimizing complications and maximizing effectiveness for our patients. We believe that Rsom can help us do so. Thank you very much for your time and attention. I'll gladly take any questions now. This is my email along with Dr. Kane's email in case anybody wishes to reach either of us in the future. And my references are here. Thank you.
All right. Thank you very much, Emily, for the excellent presentation. I will